Bonjour, hello everyone. I see many young faces in the audience, so I thought I would just start by something I talk to my graduate students about. Can you hear me? Is this okay? So, as a graduate student, I always found it very intimidating that my professor was much smarter than I was. And if I spoke to my professor, my doctoral advisor, he or she would always tell me that his or her professor was even smarter than he or she was. And I think as a general matter, if we go back in history to Plato or whatever, we haven't become any smarter over time. But the great advantage if you're a doctoral student or a postdoc now studying health economics is that computers are much faster. And so you don't have to be smarter than your dissertation advisor because the machine on your desk is smarter than the machine that was on his desk 30 years earlier. And we can now answer questions we could never answer before. And we can answer them quicker. Our productivity has gone up as economists because our computers have gotten faster. And that actually turns out to be quite important. I'm going to try and be a bridge between the session we just had and the rest of the panelists to talk a little bit about the opportunities, the methodologies and opportunities that are available to us because of big data. And I want to talk about evaluation and talk really about randomized and non-randomized approaches to evaluation that build on very large, generalizable data sets that were designed for other purposes. So these could be administrative data sets, epidemiological data sets, any kind of data set, but this is the data exist before you come to the scene. And that's really the context in which I want to frame my remarks. And I want to talk about two kinds of approaches. I'll spend just a few minutes on the first one and a little bit longer on the other. So the first one, which has a big vogue right now in the United States, is what I would call purposively designed randomized experiments in the context of existing data. So purposively designed, you intended it, you as the researcher designed the experiment in the context of a data set that already exists. Maybe the best, and these are very popular and very desirable because you can do very small experiments and they can be very cheap so that you can do experiments where you never could do experiments before, and you can actually do many of them, although people haven't done many of them. But in principle, if you could get your operation going, you could do an experiment every 2 weeks. Let me give you the poster child example of this, which is not a health experiment, but I think you will easily see the health applications of it. An educational economist conducted an experiment in New York City. The school system in New York City has some 2 million children in it, so there's lots of observations. He conducted an experiment that gave small rewards to students with very good grades. Not a lot of money. If you had tried to do this as a traditional experiment, it would have cost an awful lot of money in order to get enough sample to be able to see whether anything happened or not. But this economist used the existing database of the New York City Department of Education. They already collect information every day about whether students are in class or not, and at the end of each year, whether they passed their courses or not. So he did this experiment in the entire city of New York City for $50,000. You can imagine, policy researchers are very excited about this. Imagine all the things that you could do on this scale by just making small modifications and using existing data. Right now, we're in the works on a similar kind of study in the health field. The New York City Department of Health wants to do some mental health innovations, some innovations in community health clinics around mental health. They are going to choose randomly a selection of community health clinics in which they will introduce this new mental health intervention. They will collect no data. We already collect the data on the insurance claims of all of these patients. We have been doing it for 20 years. We can take the data that are already collected, just pay for the experiment, and look at the results. So these are deliberately designed, purposefully designed, randomized experiments that can be done inexpensively and rapidly. And I think there's a lot of opportunity for that. And the key with big data there is that the experiment can be small because the number of observations is large. These examples reduce cost, but they retain some of the logistical and even ethical dimensions that are challenging in randomization. Providers don't like to be randomized. You have to provide consent, informed consent, different kinds of things. They got away with that in the education experiment. I don't know how. But in healthcare, we would have had a problem. So there's also a big space of what I would call non-purposive, not deliberately designed or ex post designed experiments. So situations where you can use either experimental or quasi-experimental methodologies to investigate problems, and you didn't design the experiment up front. Here, I would say, so these studies, and I'm going to go through many kinds of them, have the particular characteristic. They combine large data, and that's what we just heard about before, with rich institutional knowledge. It isn't enough to have the data. You really have to combine it with somebody who can ask the right questions of it, and I will come back to that in the end. I want to talk about three kinds of approaches that fall into this category. So the first one, I think, is what I would call serendipitous but formal randomization at the individual level. So what do I mean by that? So again, let me start with a very classic experiment, and then I'll come up to the more recent interesting one. The classic experiment is a paper by Joshua Angrist, probably published in 1990, trying to ask the question, did service in the Army in the United States during the Vietnam era, did that advantage or disadvantage people? Did men who served in Vietnam, was it worse for you or better for you to have served in Vietnam? What's the consequence? Now this is a very challenging problem because for those of you who are old enough to remember all of this, you could exempt yourself from going to Vietnam by going to school. And so there's a natural relationship that people who went to school do better, and so it would appear that going to Vietnam is bad for you simply in consequence of this behavioral change. But Josh Angrist realized that going to Vietnam didn't only depend on when you went to school. There was a draft lottery. So there was a lottery that the federal government of the Army ran. They pulled numbers out of a hat. It wasn't a hat, but they pulled numbers. If you had a low draft number, you were not likely to be drafted. If you had a high draft number, you were likely to be drafted. Draft number was between 1 and 365, and it corresponded to a day in the year. Josh Angrist said, if you're born on February 3rd compared to February 4th, there is no reason your income should be different later in your life. The only reason it might be different is because February 3rd, I'm making these numbers up, February 3rd was a low number and February 4th was a high number. So let's use this lottery to understand the consequences of the Vietnam War. This led to the widespread use of a technique called instrumental variables in economics, but it is based on the idea that somewhere there was a real lottery. Do you see that? So the classic new experiment of this type, which has been tremendously influential, Amy Finkelstein, an economist at MIT, was driving her children to school one morning when she heard on the radio that the state of Oregon in the United States had run out of money for its health insurance program for poor people. And rather than putting people on a waiting list to get onto the health insurance program, which is what states usually did, they had decided to run a lottery for health insurance. If you won the lottery, you were able to get health insurance. If you lost, you were not able to get health insurance through this program. She said, lottery, health insurance, I'm on it. And essentially she was able to use the administrative data that were routinely collected in Oregon at the time to be able to evaluate the effect of winning or losing health insurance using this lottery. It turns out some of the really interesting results of that study show that, for example, health insurance is extremely useful in the care of depression. People who are depressed and get health insurance do much better, but it has much more muted effects on diabetes. You wouldn't necessarily have expected that beforehand, that the effects on depression would be so much stronger than the effects on diabetes. So, interesting experiment with the lottery. A second kind of experimentation, so you're very unlikely to find a lottery, but if you ever hear on the radio that a lottery is taking place for anything, run for it. So the second kind of randomization that you can also use, however, is what I would call triage randomization, or an informal kind of random assignment. And here again, let me give you some examples of the kind of work it is, not in healthcare, and then I'll try and move a little bit to healthcare situations. And I have one special one for Tom. Here are some of the interesting examples. It turns out that children, I don't know if it happens the same way in France, if a family is having a lot of difficulties, there is a child welfare agency that comes in to evaluate the family and decide whether the children can be kept with the family or need to be put into foster care with a different family. Do you have a similar system here? Okay. It turns out that some caseworkers, when they see a family, are much more likely to make a referral to foster care than are other caseworkers. So if you get a certain person, Mrs. X, then you're likely to be sent to foster care, but if you get Mrs. Y as your caseworker, you're going to be left with your family. And the allocation of caseworkers to clients is fairly random. It's not using a lottery, but there's nothing about the client that is related to which caseworker they get. Using the caseworker assignment, where you assign to Mrs. X or Mrs. Y, it was possible to show that we were over-assigning children to be taken away from their families. Children who were taken away from their families did much worse than we would have expected otherwise. Similar studies have been done in the juvenile justice system. Some judges send youthful offenders to prison, and some send them back to their families with a firm warning. It turns out it's much better to give them a firm warning. They're much less likely to get back in trouble again. They did it in the same way using this caseworker assignment. That is, using information about how the practitioner treats all his other patients to make inferences about how you are treated. Do you see that? If you're randomly assigned to the practitioner, we can make inferences about how you are treated. So if you live in an area with a lot of hospitals, turns out that the hospitals are getting a lot of private insurance in the United States, it turns out that the hospitals all go out and buy surgical robots. This probably happens in France too. If you live in an area where there's only one hospital, probably the hospital doesn't bother to buy the surgical robot, but if they're in competition with all the other hospitals, everyone wants to have the machine. And it turns out, if you live in an area where there are many hospitals with private insurance competing to buy surgical robots, and you're a man, you're much more likely to have your prostate removed. Because there are robots, and this is how it happens. Again, it's about the treatment. You're randomly triaged to the treatment. Many more examples of this, using the weather. If it's snowing, different things happen. You have the large data set already. We see that the weather, we can match it to the weather, and we can see whether asthma hospitalizations are greater when there are changes in weather. And I know that this is special for Tom. No one else in the audience is going to get this, but I worked on the design of the American health insurance reform. And when we were working on it, we wanted to know, how will we evaluate whether the health insurance reform actually affected people or not? The problem is the health insurance reform is going to happen on one day across the whole country. So we won't have any control group. But the computers failed. In some places, the health reform happened just the way it was supposed to. In other places, the computers failed. There's no reason to believe that the computers failed for reasons associated with the health reform. So we're able to use the computer failures to say, if you were assigned to a state, you lived there, where the computer failed, you were less likely to be insured than if you were assigned to a state where the computer succeeded. Do you see that? So we can take advantage of serendipitous things that happen to people using the big data to make inferences. The final methodology, which I am not the only one who thinks it is terribly underused in medicine. I just saw an editorial in Science making exactly the same claim, so I feel much better. It's something called regression discontinuity design. And I would think that it will be particularly useful in France, which has a very Cartesian logic, right? So regression discontinuity design exploits the fact that there are a lot of rules. And let me give you some examples of studies that have been done using regression discontinuity design. Hospitals are often paid by the day. Does that happen here as well? Sometimes for certain services, the hospital is paid a rate by the day. A patient who is hospitalized at 11:55 at night, or 23:55, doesn't look very different from one who is hospitalized at 05 in the morning. But from the hospital's perspective, very different situation. They get a payment for the day from the one who was hospitalized at 11:55 and not from the one who's hospitalized at 12:05 in the morning. Do you see the difference? In the US, insurance companies are required to pay for 1 or 2 days of postnatal care. But if you give birth to your baby just before midnight, that's 1 day. Those 5 minutes are one of your days, right? And the next day is the next day. So regression discontinuity design compares babies born just before midnight to babies born just after midnight. Shouldn't make any difference clinically. Doesn't make any difference in terms of people's outcome. The only reason it could is because the hospital is paid differently. Encouragingly, it turns out no. You probably don't need that extra day of care. For normal babies who are born just before midnight, they do just as well as the ones who are born just after midnight who stay in the hospital 1 more day. Similarly, on the baby front, because babies are very good for regression discontinuity, there are many rules governing the care of neonates that are based on birth weight. So we treat neonates born at 1,501 grams differently from neonates born at 1,499 grams. But most of the scales in the hospital can't actually measure a difference of 2 or 3 grams. So those babies are the same. But some of them are treated much more aggressively than others. Does it matter? So at least one very well-regarded study says, yes, it does. The babies who are a little bit under 1,500 grams do much better than the ones who are just over 1,500 grams because they get a lot more care. At least this is the only reason we can think of it is that they get much more care. Many more studies of this type using the day on which you were born. For example, in the United States, you can enter school if you are exactly 5 years old on September 1st in some cities, but not if you're 4 years and 364 days old on September 1st. So what's the difference in outcomes for children who are 1 day younger or 1 day older? And I think there are so many opportunities to use this kind of regression discontinuity design. So one of the things I would take from the panel we just have is that there is much more data than there are good questions. I know that sounds strange, but it's not the data that are in shortage, it's the questions. And with all respect to data scientists, they don't know what questions to ask. They are not the ones who know how to ask this kind of evaluation question. We actually had this happen at NYU. We created an enormous data science unit full of computer scientists and mathematicians. They put a lot of data together, and then they waited for people to come to them. And nobody came. They didn't know what to do. They sat on all this data, but they didn't know what to do with it. Economists are excellent at this kind of question. We are trained to think in this kind of quasi-experimental way, to ask what is a way that we can find changes in the environment around us and answer a question we care about. So I thought I'm going to mangle my French terribly, but I was trying to find the right quotation on it. And the quotation in English, so I wanted to find the translation of it, you will all appreciate this, is "Fortune favors the prepared mind." That's what we say in English. But actually the better statement of it is Pasteur, who said, and this is exactly on point, "Dans les champs de l'observation, le hasard ne favorise que les esprits préparés." So I think that's what we need to bring to the table is les esprits préparés, and the data are waiting for us.
I should begin with an apology. I had intended to break with the format and show you some slides, particularly to share some pictures with you, but the technology has conspired against me. The version of the PDF that I've brought along isn't going to work, so I can see the slides. I'm afraid you can't. I was also slightly daunted by the topic to span the range of uses of econometrics within the health field. So I'm very grateful to Sherry, who's really done a large part of the job for me. Because certainly from the journals that I'm involved with, the conferences that I'm involved with, it's clear that the overwhelming majority of applied work using econometrics in the health field falls under this general umbrella of non-experimental evaluation of treatments, of policies, of interventions, using the kind of methods that Sherry has described. So using our familiar regression tools, perhaps extending those to use things like matching techniques to adjust for the confounding factors that we can observe in our data, but then also moving on to things like instrumental variables, difference in difference analysis. If we have longitudinal data, we can allow for unobservable characteristics of individuals that remain constant over time, using regression discontinuity design, which I'd also agree is relatively underused within the health economics, the health policy field, but has great potential as well. So that's been covered. What I'm going to do is focus on a narrow area of the use of econometrics in health policy and health economics. And Randy's already talked about this, the idea of using regression-based methods to estimate models for individual healthcare costs, and then to use those models to predict individual level, in particular patient level, healthcare costs. So what I thought might be useful is to summarise some recent work that I've been doing with colleagues in York, James Lomas and Nigel Rice, where we've looked at the recent methodological developments and used some of the English administrative data as a sort of test bed to compare the performance of those models. First of all, in terms of how well they predict average costs for the population as a whole, but also for particular groups of patients. But then more recently to perhaps move away from a focus on average costs and look at the distribution of healthcare costs as a whole, and perhaps in particular focus on the tails of the distribution, the right-hand tail of the distribution, the probability of observing high-cost patients in your data. So these models for individual level healthcare costs, they crop up in various places within health economics. We see them in health technology assessment, used in the context of cost effectiveness analysis, as an input into building decision models, perhaps if we want to disaggregate our analysis by particular patient groups, by demographic characteristics of the patients, for example. We see it in risk adjustment. That's the context where our data is coming from. That applies in public healthcare systems. For example, in the UK, we have a budget allocation process based on using formulas to allocate budgets across geographic regions. So the particular data set that I'm going to be using today is drawn from that kind of work. But it also applies in insurance-based systems where you're looking at risk adjustment across different insurance pools, different sickness funds, and so on. I think another area where these regressions for healthcare costs crops up is looking at attributable healthcare costs. So, for example, in the context of tobacco litigation in the US and elsewhere, people have used regression methods to try and estimate the healthcare costs attributable to smoking, for example. And more recently, we're seeing examples of studies of alcohol consumption, particularly obesity, healthcare costs attributable to obesity, for example. To do that, you need sort of counterfactual estimates, and people use these cost regressions in order to construct those. So I was going to show you a picture of the distribution of healthcare costs in our data. We're using a data set that Carol mentioned earlier, so administrative data on hospital discharge. What we're going to look at is annual costs for inpatient care, hospital inpatient care, so summing up all the episodes of hospital care over a calendar year. And if you look at the distribution of that across individuals, it certainly doesn't follow a normal distribution. It has an irregular shape, very skewed, a long right-hand tail to the distribution, and in this administrative data we were using, it's not very well behaved. When you look at survey data, smaller samples, often it'll be relatively smooth. We've got lots of spikes in the data as well, reflecting the underlying way in which the data is generated and collected. That raises some of the more general issues that arise in trying to do a reliable job of modelling healthcare costs using econometric techniques. We had discussion earlier about the role of zeros. we're going to follow the track of discarding the zeros in the methods we're going to compare. That's because we're using administrative data, and in fact to get into the administrative data you have to have a hospital episode. So in fact there are no zeros in the data we're using for comparison. With survey data, social survey data, often you'll observe individuals who don't happen to use healthcare during the survey period. And depending on the age group you're looking at, depending on the interval that you're measuring healthcare over, you may end up with a substantial proportion of zeros. And that raises a statistical issue in terms of how best to model those zeros. Costs shouldn't be negative. So if the data is measured accurately, cleaned up and so on, we're dealing with a non-negative outcome. So we need to choose appropriate statistical models that are coherent with that, consistent with that. Another feature of these individual level data on healthcare costs is that it's not just the average healthcare costs that vary across different patient groups, that vary with the characteristics of the patients. So often other features of the distribution, the variability of costs, perhaps also the skewness of costs, will vary across groups in a systematic way. So we'll have to deal with things like heteroscedasticity and perhaps the higher amounts of the distribution also being a function of our covariates. When we look at the data, we'll see that it's both highly skewed. There's lots of observations concentrated in the left-hand tail, relatively few in the right-hand tail, but the right-hand tail extends well out into high levels of individual costs. The data's heavy-tailed relative to what you'd expect from a normal distribution. And also, it may not be the case that a linear model is the best way of capturing the influence of covariates on healthcare costs. So a linear model implies a constant additive effect of your covariates on the healthcare costs. It may be that a multiplicative model works better, that the covariates have a constant proportional effect, or perhaps some other functional relationship between your average costs and the characteristics of the patients that you're looking at. So I'll just say a little bit more about the characteristics of the hospital episode statistics data that we're using. Our purpose here is to use it as a test bed. We're using it because it's a large data set. It's administrative data. It's large. It's not big. It's not smart in the sense that we were talking about earlier. But it's large relative to social surveys. So we're looking at 1 year's data. That gives us just over 6 million observations on annual hospital inpatient costs. On average, the costs are about £2,600 a year. If we look at the median rather than the sample mean, it's much lower, around about £1,000 a year. Another sign of the fact that we have heavily skewed data. If you split the distribution up and you look at the proportion of people who have costs above certain thresholds, for example, if we go to £10,000 as our upper tail of the distribution, then we've got about 4% of our data, 4% of individuals have healthcare costs above £10,000. So a relatively small proportion in that upper tail, but those 4% of individuals account for 29% of the total hospital costs. So they're influential in terms of the overall picture aggregate spending on healthcare. So I've got a quote here from Anirban Basu, who basically makes the point that in terms of choosing a statistical model for the distribution of individual healthcare costs, we can't really turn directly to economic theory as a guide to choosing functional forms, choosing which probability distribution is going to work best. There may well be things we can learn from economic theory in terms of structuring the problem, understanding the underlying behaviour, but in terms of the statistical issue, essentially what we need to do is go to the data and compare how different methods perform in practice. So the range of methods that we've compared in this work, we use the sort of standard approaches. We start with linear regression, applied both to the level of healthcare costs, but also applied to transformations of costs. I've mentioned the logarithm of costs. often that'll give you a distribution that is approximately normal, looks a lot like a normal distribution, but you might use the square root of costs or other transformations of costs. In the recent health economics literature, I guess the conventional wisdom has shifted away from those linear regression-based approaches, and people tend to use generalized linear models now, where we specify the mean of the data, the mean function, the relationship between the covariates and the mean costs, and we specify what's called the distribution of the data, the relationship between the covariates and the variance of healthcare costs, and put those together in a generalized linear model. So we look at those. We also look at some more recent developments, particularly motivated by the idea of trying to fit the whole distribution, trying to do a good job of fitting the tail probabilities. So we look at some flexible parametric models. For example, Will Manning and co-authors introduced the idea of using the generalized gamma distribution, not for survival, which is where that distribution is sort of most used, where in a sense it originates in the econometrics literature, but the idea that survival distributions look very like the distribution of healthcare costs. So the generalized gamma as a flexible survival model may do well as a flexible model for healthcare costs. In some recent work with James and Nigel, we've also looked at the generalized beta distribution of a family of distributions. And I suppose the idea with these flexible parametric models is to find a distribution that nests some of the more familiar special cases, nests things like the log normal distribution, for example. So we compare those. We compared some semi-parametric approaches. For example, the extended estimating equations approach that Anubhav Basu has developed, which is an extension of generalized linear models. We've used finite mixture models, a way of allowing for individual heterogeneity in the data, unobserved individual heterogeneity in the data. And we've used the conditional density approximation approach. Again, a more semi-parametric way of approximating the underlying distribution. So we put all of those together using the HES data in a sort of quasi Monte Carlo design, is how we've described it. So basically, we've got these 6 million patient observations. We split those in two. We use half of the data to estimate our models, and then we use half of the data to validate the predictions from those models. Within the estimation sample, we then take random samples of different sample sizes, focusing on the kind of sample sizes that you'll often have in social surveys. So small data, in the context of today's discussion, 5,000, 10,000 observations. And we take multiple samples. So we can estimate the model many times, see how well it performs on the validation data, the other 3 million observations that we've left to one side, and see how well the models perform in terms of prediction. This work's due to be published very soon in the Journal of the Royal Statistical Society, Series A, so I won't go through the results in detail. What's striking about when we compare the results in terms of how well they predict the mean of healthcare costs is some of the conventional approaches do pretty well. So when we use standard regression, but with a square root transformation of the healthcare costs, when we use generalized linear models with a square root transformation, a square root link function, they perform pretty well. The conditional density estimator approach also performs well. So basically splitting the range of data up into intervals and approximating the shape of the distribution by sort of smoothing out a histogram, essentially, to do that. So that's in terms of how the models perform in predicting average healthcare costs. The more recent work we've been doing, which has just been published, the latest issue of Health Economics, focus more on the full distribution. So when you look at the data, those tail probabilities, for example, the probability of having costs greater than 10,000, they do vary. The shape of the distribution, particularly the size and shape of the tail probability, varies across different patient groups defined by their characteristics. So in our case, we're using risk adjusters like age, gender, and ICD codes. So the kind of covariates you'd use in a risk adjustment model. So in the work on distributional methods, as well as using the methods that I've described earlier, we throw in some additional techniques. which have been developed primarily in the labour economics literature over the last few years. And these are methods that are designed more specifically to estimate the full conditional distribution of the data. So to estimate what's the probability of costs greater than 10,000 given the characteristics of the patient. So these have been used in the context of things like gender pay discrimination, not just looking at differences between men and women in terms of average earnings, but also looking at differences across all points of the distribution and decomposing those wage inequalities using two sets of methods that we've applied here, some which estimate the distribution directly, what you can think of as distributional regressions, basically approximating the distribution as a step function, using logit models essentially to approximate the full distribution. Others that, rather than working with the distribution itself, work with the quantiles of the distribution, using quantile regression methods, and then invert those to get back to the underlying distribution. So we put those into the mix as well, and there are no clear-cut winners in this comparison based on the HES data, and I think it's fair to say you would draw different conclusions if you use different data sets as well. But it does appear that these distributional regression methods do perform particularly well in estimating these tail probabilities, certainly when you split by covariates. So I think there's a lot of potential in those. It's early days in terms of using these methods with health data as far as we're concerned. But it's also the case some of the more conventional methods, for example, the log normal distribution, also does a good job of predicting particularly the tail probability for that group of patients who are, in a sense, the high-risk patients, most likely to be in that upper tail. Okay, I know my time's running out, so I think I'll probably stop there, actually. So, thank you. Thanks.
So, after Sherry's presentation, I have to mention that I think all economists use a set of various methods, including quasi experiments, but I seem to be here to talk more about RCTs, so that's what I'm going to do. And so what I'd like to do is maybe illustrate that there might be important stuff for which we don't have a quasi-experiment available, or we may have one of those many lousy quasi-experiments that are also around, because Sherry picked up the very nice ones, the Vietnam draft, and the nice regression discontinuities and so on, but it's still, there's a lot of stuff for which we want to know things, and we don't have the nice quasi-experiment around, and this is where randomized experiments are very useful. But I will also discuss that it's a complicated issue in many respects, and it's not sure that we all know exactly how to deal with those questions. I want to start this illustration of the fact that there are important questions for which you may need a random experiment, by maybe the most famous random experiment in health, which is the Rant health insurance experiment. And it's an experiment that took place in the 1970s, and the question at the time was to convince people that individual health behavior depended, at least in part, on prices and economic conditions of typically an insurance scheme, which was not something obvious. And this experiment was very influential in showing that indeed prices were important to people's behavior regarding their health and medication. But this is typically the question that's very difficult to answer without an experiment. And what that thing did is they took a representative sample of 2,000 households, and they offered 6 different schemes of insurance mechanism with how much you have to pay on your own, how much you're insured depending on how much health spendings you have, and so on. And this allowed the people to understand in some detail what was the behavior of individuals with respect to health and choice of insurance. And so it's pretty ambitious, and the result, because I think they've been randomized, they have been very convincing and influential in showing that there are moral hazard issues in these questions. And something that was probably that couldn't be dealt with such precision and convincing capacity without this a randomized experiment. Now, it doesn't mean that there are not many other things to do, and I want to give you another example of something I think fancy, also on the insurance choices, and maybe which is a continuation of the Rant intellectual program here. There is in Medicare, there is a scheme called Medicare Part D, where people are offered additional scheme with a number of benefit structures. So my understanding from the project I'm going to quote now is that people have to choose among 40 to 60 different plans with some out of the money, whatever structure of cost and reimbursement. So it looks like, I mean, in the Rant experiment, you offered people one of the 6 things, and you see that people behave somehow strategically. But here you have another issue, which is that if you give too much choice to people, there may be what the authors call comparison friction, that it's too difficult for people to choose rationally amongst such a large number of choices. So it might be that people are strategic and behave rationally with respect to those things, but then there is a cognitive cost to really behaving optimally. And there's a nice experiment, and this is also where you probably need a randomized experiment to get into this into detail, where what they do is they help people with information by accessing the data, the health data of people, and looking at what are their spending given what illness they have. And they tell people, given the kind of spending that you have and the kind of illness that you have, here are simulations of how much you would spend and how much you would save under scheme A, under scheme B, under scheme C. So they help people by providing them personalized information and showing them, simulating what are the implications of the various schemes, and they, of course, randomize people for whom they give this information and for whom they give less structured information, less personalized information. And they do find that, I mean, we're talking about Medicare people, so these are significant numbers. They find that they can help people save about $100 a year by making more rational decisions in their choices under this overwhelming informational problem. And $100,000 can be considered a significant amount for that population. So these are 2 examples of experiments in health where you're tackling pretty complex problems, and probably you want to have an experiment that allows you to go to the very point that you're looking into. Some of the counterexample, I want to get back to the Oregon experiment. So you mentioned the Oregon experiment that Amy Finkelstein and co-authors worked on, which is literally an RCT. The only thing is that the initiative of the RCT was not the researchers, it was the administrations, yeah. But it's literally an RCT. Yeah. It's just that Amy was fast enough to understand that someone had done an RCT for her, and she just had to pick it up. So the thing is, so what this is about, you said it already, it's about expanding Medicaid to the marginal population. Is that correct? That didn't have Medicaid yet, because Oregon wanted to expand this, but because they didn't have the money, they randomized the people to whom they offered this. So the question is, why wouldn't you use the Rant experiment parameters to infer what people would do? But this is not going to work, because Sherry will probably explain this much better than she does, because I'm not working on health, by the way. That's a detail. But it's probably difficult to infer from the theoretical framework that you can build from something like the Rant experiment, to infer something that will work precisely in the specific context of that program on that very population, at a state also of the supply of health that is not the same as in the 1970s and so on. So it means that probably you also need more ecological, reduced form, policy experiments on the side of those more structural things where you manipulate a lot of things to understand details of the economic behavior of people, but you also need more ecological things, and this Oregon experiment is one. I just have a program that is a real political program offering Medicaid to people. What happens? And what happens is, in fact, I'm not sure I understand what happens in this thing, because on the one hand, you see that people spend more in health, they go more into health services, including emergency services. They're more happy. They declare they're more healthy. They very rarely bear the huge financial risk that some people bear, 5% of their sample, when suddenly they have to find $10,000 to get treated that they probably don't have. So all those things are working fine. But then on the other hand, their health is not better. When you measure their health 2 or 3 years, well, there's this discussion about diabetes, right? And depression.
Depression is better.
Yeah, sure. Depression is better. But my understanding, so you probably correct me with the details, but my understanding is that their health is not that better, okay?
Except depression. Only depression. Depression is really better.
Depression is really better. Yeah, sure. I get that point. No, yeah, we can discuss this in detail. But the point is there might be something that is not entirely clear. A slight contradiction between the fact that you have certain impact in health behavior and access to health services, and maybe an impact on measured health situation that is probably not exactly fitting that thing. And then you go back to the question of, so do we have enough with that very policy experiment to really understand things? And maybe, I don't know, maybe there's a moral hazard issue here, or another selection issue that you induce more risky people, so they spend more in health, but because they're more risky in the end, they're not in better health than the control group. Or maybe there's moral hazard. I have no idea, and Sherry will give the answer in a minute, I'm sure. So this is the kind of experiment that is necessary, because the more theoretical kind of stuff may not give you they give you general frames, but maybe not the right answer to the very specific question that this program in Oregon is raising. But on the other hand, you see that when you've done this, you're left with a handful of questions for which you might have hoped that in the Oregon experiment you could have manipulated more things to understand more precisely what is exactly the behavior of people and understand where this contradiction comes from. So I think my understanding of all these issues is that, and it might be the same, I mean, maybe it's not specific to RCTs actually, but it's certainly an important question for RCTs, that there's always that tension between doing things that are more structural, that answer very precise, delimited questions, but that might move too much on the lab side, and randomizing experiments in a very ecological policy environment, learning things that have direct policy implications, but in many cases that are also surprising, not well understood in details, and for which you would like. And in the end, you'd like to have both things. You'd like to have very ecological experiment, but you want to have Martin allow you to manipulate many things among that experiment, and have many treatment arms, and this is always a very complicated thing, because for the institution, the institution is not a lab, so we're always all of us in between those things. And I think one issue the smart RCT would be to solve that issue in a way that is compatible with all the constraints in the field. The last thing that those two experiments, am I on time? Yeah. Last thing that those two experiments illustrate is, again, the importance of data. For instance, this very nice feature of one of the experiments I mentioned that they're accessing the medical data of people so as to personalize the information that you provide them very precisely and see what happens. And in the Oregon experiment, they have access to huge, fantastic amount of data, administrative data on people's spending, on people's attendance into different medical services all over the state. And that's a big issue. And I think in the French context, there is also a lot of administrative data. So I'm not a specialist of that, but my understanding is that it's very hard to access administrative data in this kind of research framework. But it's clear that those few examples show how valuable it is, obviously, for this kind of questions to access administrative data. But of course, they're not sufficient. So the self-reported health questions, the financial aspects, do you have to spend $10,000 suddenly and so on, are things that also require ad hoc questionnaire surveys to people to know more. So here again, I think the right way to work is to be able to access a lot of administrative data, but also don't forget to run surveys that will give you information that are not in those data. This was a few things I wanted to share with you. Thank you.